I would really appreciate ideas, even though I've been trying for about 15 years to do that. The second one is about the acid-base. I'll make the disclosure now, although it will apply to the acid-base talk, which is in acid-base, I'm not going to use the Stewart approach. I'm going to use the classic approach. The Stewart approach is a fine, well-accepted, physiologically based, quite correct approach to acid-base, but it's not used for the boards. Every year, I look at the different modules that the ABIM offers. I look at the critical care ones and see if the questions have changed. Now it's good. They actually put who the authors of the modules are. And for the critical care modules, the authors are not nephrologists. They are your peers. They are intensivists. And the acid-based questions continue to use the classic approach. So since I only have a half hour, I'm not going to talk about the Stewart approach. Not that I have anything against it. It's just that it's not going to be on the boards. So I've given my 2 disclosures. So let's get started. So for electrolyte emergencies, our goals will be to talk about hyponatremia, quite a bit, hypernatremia a little bit, and then some key points about hypo and hyperkalemia. So this is a water and potassium talk. Let's start with a question. 44-year-old man with schizophrenia is brought to the emergency room from his group home after a witnessed tonic-clonic generalized seizure. He was well until earlier in the day, at which time he became progressively somnolent. His medications include haloperidol, quetiapine, and citalopram. On exam, he is afebrile, blood pressure is normal, heart rate is normal, he's somnolent but arousable, and he's following commands. He's euvolemic, and there are no focal findings on neurological exam. He has a spontaneous urine output of about 120 mL per hour. His laboratory tests show a sodium of 116, potassium of 3.9, creatinine 0.8, a urine sodium of 35, a urine potassium of 15, a urine osm of 92, and a plasma osm of 240. What is the most likely etiology of this man's hyponatremia? SIADH, psychogenic polydipsia, pseudohyponatremia, adrenal insufficiency, or cerebral salt wasting? Okay, very good. So almost 60% got the right answer, which is psychogenic polydipsia. And the key factors there are obviously in the history. A man with schizophrenia, polydipsia is a very common feature of these patients, but really the key was the fact that he was euvolemic with a low urine osmolality. That's really the key to the diagnosis. So, to approach the diagnosis of hyponatremia, we ask 3 critical questions. The first one is it real? And to ask if it's real, we see what the plasma osmolality is. And if the plasma osmolality is depressed, then it's a real hyponatremia. If it's not, then if the osmolality is normal or high, then the patient has something else, either pseudohyponatremia, which is not a very common problem. That's related to the method of assay of sodium, and it's most commonly caused by very high plasma proteins. So, for example, patients with myeloma or other paraproteinemias, or very high lipid fractions, typically very severe hypertriglyceridemia, because it's very hard to get cholesterol very high. But if you increase some other fraction of blood that's non-water, so either the protein or the lipid fraction, that can fool some of the, or fool most of the measurement methods. And even though we don't use flame photometry anymore, the method of dilution that we use is not foolproof for this. So if you have severe hyperproteinemia or severe hypertriglyceridemia, you can see pseudo-hyponatremia. So that's important to think about. The second one is uremia, because the BUN, the urea nitrogen component, will cause an increase in osmolality. And the last and most important one, because of frequency, is transpositional hyponatremia, especially that caused by hyperglycemia. So if you see someone with hyperglycemia, so a good number to remember is that about 1.6 milliequivalents per liter will go down for every 100 milligrams per dl of glucose that goes above 200. So you can see if you have sugars in the 6, 7, 800, 1,000 range, you can see quite significant drops in serum sodium based on that. So if you have low plasma osmolality, you have true hyponatremia, so then you can move to the second critical clinical question, which is the patient excreting water appropriately? Is there an appropriate renal response to that? And if the urine osmolality is low or greater than 100 arbitrarily, then that patient has intact water excretion. The problem is that the patient is going over the ability of the kidney to excrete water, and the diagnosis there is typically psychogenic polydipsia. An alternative diagnosis here would be someone with a reset osmostat, which can happen in several psychiatric disorders, which can happen during pregnancy. And what these patients have is simply a different set point. They live at a lower osmolality, typically pretty mild, hyponatremia in the 130 range. And the way you diagnose that is that when they get to that point, if you give them more water, they are able to dump the water without problems, but they live at a lower osmolality. If, on the other hand, the urine osmolality is high, then it confirms that this patient has ADH present. So ADH is mediating the hypoosmolality. There's a retention of water that shouldn't be happening. So that then brings the third critical clinical question, which is the ADH secretion appropriate? And that's where the volume status comes up. So remember, usually when I'm in rounds with whatever, students, residents, or fellows, my question is, what's the first question that they come up with? The volume status? No, the volume status comes in as number 3. You need to have answered 2 other questions before you get to volume. So at this time, you ask what the volume status is, and if the patient is hypovolemic, we know that volume always trumps osmolality. So it's an appropriate secretion of ADH. ADH is being recruited as part of the response to hypovolemia. And once you take care of the hypovolemia, the ADH secretion will go away. The second one is in a patient who's hypervolemic, so heart failure, cirrhosis, severe nephrotic syndrome, but especially heart failure and cirrhosis. In those patients, the ADH secretion is of sorts appropriate because it's in response to a perceived inappropriate vascular filling, so ineffective plasma volume. But that's maladaptive. So over time, that's a bad thing to have. And then finally, if the patient is euvolemic, then it's a no-brainer. The presence of ADH is inappropriate, and that's the classic situation where you have SIADH. So this slide gives you a summary of the diagnostic possibilities. So in someone who's hypovolemic, if the urine sodium is low, then those patients are losing volume from a non-renal source. And if the urine sodium is high, and that's why the urine sodium is helpful in this, then it's a renal loss, and in most cases it's a diuretic, but it can also be adrenal insufficiency, that's an important one to remember, and cerebral salt wasting, which can happen after craniofacial trauma, surgery, or acute intracranial processes. If the patient is hypervolemic, then the common causes are heart failure, cirrhosis, and nephrosis. If the patient is euvolemic, if the urine osmolality is low, are the 2 possibilities that we mentioned before, psychogenic polydipsia, as in this case, and reset osmostat. And if the urine osmolality is high, then in most cases it's going to be SIADH, but it can also be patients with renal failure who are unable to excrete water, and cases of severe hypothyroidism, and the syndrome of isolated glucocorticoid deficiency, which in some series was pretty common, but I've been looking for it and have never found a case. I have never found a case of isolated glucocorticoid deficiency, despite looking for it pretty fastidiously. Very good. So SIADH is important to remember. It's probably something with a good chance of being on the boards as a cause of hyponatremia. There are several common causes. Remember the importance of physiologic, non-osmotic causes of non-osmotic SIADH release, especially pain, nausea, and vomiting. Nicotine is another important one, although not really physiologic. Malignancies, always important to remember, especially if in lung or brain, although there have been others reported. Think of any pulmonary disorders and any CNS disorders as also being potential causes. And finally, always take a very close look at the drug list. And what this slide does, it gives you a roadmap for common drugs. This is something that I think most of you have looked at in practice. And the interesting part is that there are many mechanisms whereby drugs can cause SIADH, either because they are ADH analogs, that's what happens with DDAVP or oxytocin, or they can increase ADH secretion, they can increase the renal sensitivity to ADH, or they can have mixed or incompletely understood mechanisms. So by several ways, many of these drugs can cause this. The ones that you have always to remember are antidepressants and antipsychotics. Always keep these in mind because they are so commonly used and are such a frequent cause of SIADH. In patients coming in the door, especially in young patients, always think of some amphetamines, in particular ecstasy, as a cause of SIADH. Always important to remember. So, we now have a framework for the diagnosis. Let's talk a little bit about treatment. So this is the second question. 60-year-old woman with hypertension, GERD, depression is admitted with progressive confusion. She has no other symptoms. Medications include hydrochlorothiazide, valsartan, omeprazole, paroxetine, and aspirin. On exam, she's afebrile, blood pressure is 130/68, heart rate is 88. She's somnolent but is easily arousable. She's disoriented to time and place. She has no edema. CNS exam is non-focal, and she has a spontaneous urine output of about 50 an hour. Relevant laboratory tests, she has very low sodium, 112, low potassium, 3.2, creatinine slightly up, 1.2, a plasma osmolality that's depressed, 236. Her urine sodium is 75, her urine potassium is 50, and her urine osmolality is high, 395. What is the most appropriate initial management for her? Fluid restriction, IV saline plus furosemide, IV saline plus KCl, hypertonic saline, or intravenous conivaptan. Okay, good. So a small majority got what I think is the right answer, D, and two other were fluid, just plain fluid restriction, or saline plus potassium. So the key here is to recognize that she has likely, so multifactorial hyponatremia. She's on diuretics, so thiazide diuretics. She's on an SSRI, paroxetine. There may be a role of her PPI. But she has significant CNS symptoms. So we need to act quickly to get her out of trouble. And so just fluid restriction would definitely not be acceptable. giving her, because she's potassium depleted, giving her some volume, although she's not obviously volume depleted, but you could argue, give her some volume, give her some potassium, that will improve her serum sodium, would not be unacceptable, but I think would be too conservative for someone who has such severe hyponatremia, below 115 arbitrarily, and CNS manifestations. So our choice, this is a real case, our choice was to use a hypertonic saline, and I think that most would agree that that's the right answer. Conivaptan is a combined V1 and V2 receptor antagonist. It's only approved for using hypervolemic hyponatremia in the setting, so usually patients with CHF, but there's probably there's no agreement that using a V2 receptor antagonist in patients with symptomatic CNS involvement is safe. So that would not be the best answer either. So let's talk a little bit about what factors are important in deciding how to choose treatment. So this is a brief reminder of physiology. This is the only animal data I'm going to show you. So if you induce hyponatremia by giving ADH to an animal, you see very promptly an increase in brain water, and that brain water decreases over the ensuing 72 hours. The reason that brain edema gets decreased is because electrolytes and non-electrolyte osmolytes start egressing from the brain. So initially, it's largely just electrolytes, sodium and potassium. But starting by the end of the first day, there is some extrusion of non-electrolyte osmolytes, and that peaks at about 72 hours. So these non-electrolyte osmolytes are largely amino acids and polyalcohols, and they take time to leave. And this is what helps define what acute and chronic adaptations to hyponatremia are. So electrolytes go in and out pretty quickly, but non-electrolytes go out slowly and go back in even more slowly. So this is why we have to be careful when we correct hyponatremia, that we don't do it too fast. So the two elements that guide our decision on how fast to treat hyponatremia are, number one, the presence of cerebral edema, and whether it's manifest or not. Manifest, for example, in the case that we just did. So the presence of cerebral edema, we need to attack pretty quickly so that we can relieve symptoms, we can prevent the progression of neurologic dysfunction, and we can prevent respiratory arrest from herniation in patients who are at high risk. The second component is exactly the opposite, is taking into account those non-electrolyte osmolytes to make sure that we avoid excessive correction so that we can prevent the syndrome of osmotic demyelination that we'll talk about in a minute. So, consensus guidelines of how to get there, and the Verbalis reference has been updated. There was another paper in 2013 in which they updated the recommendations a little bit, but they still say very much the same. So no more than a 10 to 12 rise in sodium for the first 24 hours, less than 18 total for the first 48 hours. One could argue that you really don't need to go up by more than 6 milliequivalent per liter or so to get the patient completely out of trouble. So that's why, going slower is as long as you don't go too slow, is fine. It's fine because most patients do okay. And that's going to be particularly important in patients at high risk for osmotic demyelination, as I'll show you in a second. The rapid achievement of a small rise in sodium is safe and advisable. You can get with a bolus of hypertonic saline, 100 mLs given over about 10 minutes, can get you up by 2 to 4 milliequivalents per liter. And we know in case reports in patients with hyponatremia, and we know from changes in intracranial pressure following neurosurgery that giving hypertonic saline in these amounts can cause significant decreases in intracranial pressure. So that's what guides our initial management. And we need to be cautious in patients who may develop a brisk aquaresis, start dumping water the minute you shut down the problem. That is the case of podomania. Remember, that first case, the guy was peeing 120 mLs per hour. So he was he got confused, he stopped drinking, and he's pouring out water. That guy, you don't need to give hypertonic saline. He'll take care of it by himself. But this lady would not have gotten there that fast. Same thing, patients who are receiving DDAVP. If you stop the DDAVP, that goes away. If you have someone with adrenal insufficiency and you start replacing glucocorticoid and mineralocorticoid, they will also dump water appropriately. So what about osmotic demyelination? So osmotic demyelination is the syndrome that, that we all worry about from overcorrection of hyponatremia. It's a syndrome of patients with severe hyponatremia and other risk factors. It rarely occurs in patients who have sodiums above 120. It usually patients typically have an initial improvement and then they get worse, typically several days later. The neurological presentation is varied. It stopped being called central pontine because a good number of patients have extra pontine involvement. They usually present with either focal motor defects, progressive loss of consciousness, or seizures. The diagnosis is primarily through MRI, once suspected clinically. And it's very important to remember the risk factors, which you see listed there. The initial descriptions were in malnourished alcoholics. We now know that hypokalemia is important, that being elderly, especially elderly women, is an important risk factor, and particularly in those exposed to thiazides. Burn patients and liver transplant patients. So in these patients at high risk, we need to be particularly careful. This was a syndrome that we usually thought of being terrible, irreversible, but more recent data with follow-up of good numbers of patients show that actually 50% have some good amount of recovery. So it's not a death sentence to have osmotic demyelination. So that's something, that's more recent data that I think is quite important and encouraging. So in making the decisions, if the patient is asymptomatic, okay to just fluid restrict. If there are mild symptoms, the options are either saline with furosemide. Okay, saline replaces sodium. Furosemide helps dump water, so it allows the sodium to slowly come up. The other option is V2 receptor antagonists. The only one we have on the market is tolvaptan, and we have IV conivaptan. So oral tolvaptan is the one that most people use for this. Extremely expensive. The alternative is urea. So if you can get medicinal grade urea, which is not easy, we've been successful at times, unsuccessful at others, but if you can get urea, it works very well. So in this study, for example, patients who had been stable on a Vaptan were taken off the Vaptan and then put on urea, and did very well. As you can see, serum sodium went up very promptly and very well. So you can give urea in escalating doses, and these patients, if they can tolerate the taste, they can do pretty well with it. And then finally, for severe symptoms or very severe hyponatremia, I think we could arbitrarily call that below 115, then hypertonic saline. This slide gives you a guide of how to dose hypertonic saline. You need to decide what your target sodium is, and then just calculate how much you're going to give per hour. Like I mentioned, a bolus is often enough to take you out of trouble, and you may not even need to give anything else afterwards. But no matter what you decide to do, the most important is to monitor the sodium closely. Hourly is very difficult, but at least every other hour, so that you have an idea of which direction things are going, especially because you want to prevent overcorrection. There are 2 studies that show that using the conventional formulae, whether you're giving hypertonic saline, as in this slide, 15% overcorrected, or if you're giving conivaptan, 39% overcorrected. So the risk of overcorrection is significant. So we need to monitor it closely. And if it looks like the patient is progressing too fast, you obviously can stop the infusion, or you should stop the infusion of hypertonic saline. You may need to give back water as D5W, or there are some protocols suggesting now that you co-administer hypertonic saline with desmopressin. I have given desmopressin back, but I have not co-administered them. I think that just by monitoring these patients closely, you should be able to take care of them. Sometimes patients who have underlying LV dysfunction especially may need furosemide to not be challenged by the volume excess that you're giving with the hypertonic saline. Now, hypernatremia. I want to tell you that hypernatremia is common in the ICU and that it's often iatrogenic and it has negative prognostic implications. So why do people in the ICU get that? Because they have a loss of drive for water. They are often confused, they are sedated, they are intubated, they are NPO, so we are their thirst sensors. So we need to do that, and we often don't do a good job at that. And finally, they have significant hypotonic fluid losses, whether it's through fever, nasogastric suctioning, increased minute ventilation for those who are not in a closed system, so those not intubated, or they are losing it in the urine. So some have diabetes insipidus, others are receiving loop diuretics or have a solute diuresis, for example, from hyperglycemia, receiving mannitol. So this is a perfect scenario to develop hypernatremia. And why does it matter? Because people die more. So in this case control study from the Netherlands, patients who developed hypernatremia in our phase, right? So these are people who developed hypernatremia while receiving ICU care, had a 4-fold increase in mortality. And the reason was mostly because they were getting either too little water or too much salt, sodium and or potassium. So it's largely our fault. This is iatrogenic hypernatremia. Every time you see hypernatremia, you need to replace water. You've got to keep it simple. Give water back. And one way to get a sense of how far down they are is by calculating the water deficit. I put the formula there for you. So that gives you a ballpark of how much you have to give to get back. But don't forget that sometimes they continue to have the processes that got them there. So you need not only to replace what was present, but what is already present, but also match continued water losses. You got to remember that there's a change. The change in osmolytes is the same as in hyponatremia, but in the other direction. So you never want to do it too fast unless it's acute hypernatremia. If not, just calculate your differences and then replace back over the course of 2 or 3 days. Limit the amount of solute intake, and that's very important to look at your IV fluids and make sure you're not giving, by solute I mean sodium plus potassium, make sure you don't give too much of that. And also remember that in some ICU, especially in the neurosurgical ICU, central DI is often a problem, and those patients would need DDAVP to correct it. I want to present to you the concept of tonicity balance as something that helps in figuring out the management of these patients. So for example, I want to remind you that the tonicity of what you give, and tonicity here defined as sodium plus potassium in anything you're infusing, let's say the IV fluids that the patient is receiving, and the tonicity of the output, the urine, assuming that there are no extra urinary losses that are significant, that will determine the plasma changes in osmolality. If your input is hypertonic to what's coming out in the urine, so sodium plus potassium in what's going in is greater than sodium plus potassium of what's going out, serum sodium will always go up. And if the opposite occurs, if the tonicity of what's going in is lower than the tonicity of what's going out, serum sodium will always fall. So this is important to understand how you cause them to develop a dysnatremia, and also important to understand how to treat them. So let me give you a hypothetical example that I'm pretty sure you see. Guy with pneumonia, complicated alcohol withdrawal. Serum sodium is 153 and has been rising in front of you for the last 5 days. His potassium is a little on the low side. His urine sodium is borderline-ish. His potassium is also borderline. He's receiving D5 half with 20 of K that has a tonicity of 77. So 77 of sodium has K, another 20, so that's 97. And his serum sodium continues to rise. And people always say, I'm giving something that only has a sodium of 77. Why is the sodium going up? This is hypotonic. So understanding tonicity balance is important to answer that question. So let's do the math. You gave him a liter of half normal saline with 20 of K. That's 97 milliosms per liter. 77 from sodium, 20 from potassium. But the urine tonicity, what the kidney is getting rid of, is only 64. 30 of sodium, 34 of potassium. So what happens? For every liter of water that you give that patient, in order to dump the sodium and potassium that you're giving, the kidney needs to excrete 1.5 liters of water. So for every liter of that fluid that you're giving, you're forcing the guy to mobilize 0.5 liter of water from somewhere else in the body. And that's why you're making that patient's sodium worse. So the result is a progressively negative water balance, purely iatrogenic. If you understand this, you will not make that mistake again. All right? So a very important point. Potassium disorders. First, general cause, I'm going to make just a few comments about these. General causes of dyschalemias, either changes in intake, low is rarely an issue, high is relevant if K secretion is impaired. You eat too much, you can't excrete, you develop hyperkalemia. Impaired excretion, if you have kidney disease or you have drugs that alter excretion, that's a big problem, very common problem. And increased excretion is a very common cause, whether it's happening through the kidney or through the GI tract, you're going to have increased losses, a big cause of hypokalemia. And finally, transcellular shifts, which are not a cause of chronic disturbances, but very important in the ICU. So things can go, potassium can go into cells and cause hypokalemia, is what happens in hyperinsulinemia, in beta-2 adrenergic stimulation, in refeeding, and in metabolic alkalosis. Or potassium can move out of cells, such as what happens in DKA, for example, whenever there's a hyperosmolar state, when cells are lysing, okay, although in that one it's not really a transcellular shift, is an increased offer of potassium. How can you figure out what of these is mostly operative? Well, you need to measure how the kidney is handling potassium. And one way to do it is by calculating the transtubular potassium gradient. And what you see there is that if you have a situation of hyperkalemia, you want to see the kidney dumping a lot of potassium. So if you do the math and you calculate the TTKG, if you have a TTKG that's less than 6, it tells you that there's not enough potassium being thrown into the urine, so that patient does not have adequate renal excretion. On the other hand, in hypokalemia, the kidney should be retaining as much potassium as possible. So if the TTKG is above 2, it's an inappropriate renal handling. So that helps you interpret if the kidney is playing a role or not in a different process, in different processes. Pearls to remember in the evaluation and management of hypokalemia. Always think magnesium. Low magnesium amplifies hypokalemia. You are not going to be able to treat hypokalemia until you treat the hypomagnesemia. Beware of hypokalemia as part of the refeeding syndrome. Whether refeeding with TPN or with oral feedings, it doesn't matter. Hypokalemia and hypophosphatemia are important things to remember. Remember that bicarbonate is caluritic. So if you're giving bicarbonate or if you're giving acetazolamide, which is bicarbonaturic, those patients will dump a lot of potassium. Remember that in diabetic ketoacidosis, patients are usually potassium depleted. It doesn't matter what the potassium is at the time of presentation. So even if people present with Ks in the 6 range, they will very quickly show that they are hypokalemic. So a general rule is that for patients who have potassiums, who present with DKA, the potassium should be repleted pretty much for anybody who has a K that's in the, above 5, below 5 or so. They should always be repleted, even if it doesn't look bad. Some even recommend repleting anyone who's below 5.5. I tend to stick to about 5. And when replacing potassium, remember that there is not a linear relationship between K deficit and what the plasma K is. So let's look at that. So if you look, so this is pairing what the serum potassium is on the y-axis with what the K deficit is in the x-axis. So if you have a potassium of 3, you've lost about 300 or so milliequivalents. So that's a big loss. So, giving 40 of K once a day or 20 BID is not going to get you replaced anytime soon. Okay? Remember that. The second one is, by the time you get to 2.5, you already have more than 500 of deficit, and so on and so forth as you go down. So remember, these patients can have very large losses. So remember that to understand why you're trying to replace and you're not getting anywhere. And you can evaluate how much potassium is going in or out by measuring the output from urine. That's pretty easy, urine potassium. The stool losses, sometimes the lab complains about processing stool specimens for electrolytes, but you should get that as well in patients who have large stool outputs or large fistula outputs. And here you have the different replacement options. Those you know very well how to use, just don't forget to not undertreat. And finally, for hyperkalemia, I want to make 2 points. The first one is the importance of drugs. Always look at the list of drugs that the patients are taking and the possibility that they could have implications to causing hyperkalemia, especially blockers of the renin-angiotensin system, trimethoprim, which blocks the epithelial sodium channel, which is responsible for mediating K excretion or as part of the K excretory process, and heparin. So some important ones in the ICU. We always treat in 3 steps. We stabilize the cardiac membrane, so control cardiotoxicity. We shift cells, we shift potassium into cells, and then we remove. So control of cardiotoxicity usually something when you're seeing EKG changes or when you have potassiums that are above 6 to 6.5. I usually don't do any of this with potassiums below 6. It drives me nuts when I see people getting K-exalate for Ks of 5.2, 5.3. Nothing happens with those kinds of numbers, so there's really no need to do that. But when the hyperkalemia is real, so let's say potassium is over 6 arbitrarily, calcium gluconate to control to stabilize the cardiac membranes, insulin and beta, plus or minus beta-2 agonists. Usually you just need IV insulin to move it into cells while you buy yourself time to remove it, which can happen either with diuretics, resins, or dialysis. This slide gives you a summary of how much you get for each of the interventions. That's bicarbonate doesn't do much, that's why we don't use it. Insulin gives you about 1 milliequivalent per liter. Dialysis gives you more, and the longer you do, the more you get. So patients in acute kidney injury and acute renal failure, that's why they need dialysis. Final word on resins. So K-exalate, I don't think it's that bad a player, but it's certainly got enough of a bad rap in the last few years because of the risk of colonic necrosis and limited evidence that it works. So we should avoid using it too liberally because of the risk of colonic necrosis, although, again, the absolute risk is quite small. But when it happens, it's pretty bad. So lots of people are trying to develop new treatments, and one of them, so there were 2 in the major journals, JAMA and the New England Journal over the last year. So patiromer is a resin, and zirconium cyclosilicate is a potassium trap. So they exchange, their oral exchange substances. In this one that was tested for, actually part of it was in acute treatment, you see that in the highest doses you got about a 0.7 decrease in potassium by 48 hours. You saw an early change by 4 hours, but that was not that significant, but it was pretty good by 48 hours. And the mean decrease was greater the baseline potassium. These drugs have not yet been approved, and we will see over time what their role will be in the hospital. It seems like in chronic therapy they work pretty well, but in the hospital we're going to see how good they are. Thank you.